Okay. Hello, everybody, and welcome. Sorry, we can't see your faces, but if anyone's in the building or around, we're in the HEU boardroom. You're more than welcome to join us. Very pleased to be presenting Dr. Michael Deml and Jennifer Githaiga, Dr. Jennifer Githaiga, who are both with the Division of Social and Behavioral Sciences and have been doing a body of work that Mike has been leading around COVID-19 and other vaccine hesitation. And we're really pleased that we can do this because it feels like a kind of rounding out of the process. Mike has been with us for a little while. He did a new meeting right in the beginning and kind of presented his ideas. And this is, sadly for us, Mike's final presentation for the division, although we hope he'll come back and visit us again. And so we're excited to hear some of the results of the work that Mike and Jennifer have been working on. So please go ahead.
Thank you. And I think people are trying to pop in online, so I'm gonna. Oh, okay.
But I can also. I'll log on.
Okay. You know how you can do that. Okay. I don't know how to do anything on Teams. Okay. So hello to the crowd here and through the crowd virtually. Thank you, Lucia, for that nice introduction. And we will be sharing some of the work that we did with the scoping review of COVID-19 vaccine hesitancy and uptake measurement tools in Sub-Saharan Africa. So just a little bit of context for this project. So I came to Cape Town in August 2021 and saw this opportunity through Leading House Africa for a research partnership grant. So we had a very short deadline. So I rounded up Jennifer, we had just met, and we organized to propose this project that fell within this funding scheme, which was designed to develop, consolidate, and expand relations and foster collaboration between Swiss researchers and partners in Africa. So as part of this project, what we did, we brought Jennifer to Switzerland for a short research stay, and then we also brought some researchers here very recently for dialogue. Part of this project involved conducting a scoping review of literature on COVID-19 vaccine hesitancy and vaccine access issues in Sub-Saharan Africa. That's what we'll be discussing today. And then the other purpose of this funding scheme is to have sustainable and collaborative networking opportunities between Switzerland and Africa. I'm quite happy to share also on here, and hopefully this works out. We hosted this dialogue on social sciences and immunization at the end of November, early December, and we had quite a large group of researchers who came and presented work on vaccination-related research, both in Sub-Saharan Africa and European contexts. So this is just a brief blurb that highlights some of that work that we did with this dialogue, and you can find that on the Division of Social and Behavioral Science Field Note website on UCT. So that's available online. I'll come back here. And just so some good news about this whole process, we're very happy that this work, this scoping review that we're discussing, has been published in BMJ Open, and it's available online open access, so you can have a look at that if you want some more information about that. So now I'll hand over to lovely Jennifer Githaiga.
Yay! Hi everyone, it's lovely to have all of you, and thank you for attending. Some of you attended our immunization dialogue, so thank you for coming again. We have a mostly virtual audience with a few sitting in here, so I don't know where to look, but I'm here, and I hope you can hear my voice. So what we just are going to try to do within the next few minutes is to introduce the topic of vaccine hesitancy and its relationship to vaccine uptake, to provide the Sub-Saharan African context, which was the basis of our work, to discuss our specific research questions and focus, to provide some details about the scoping review process, and then we'll focus on the findings from the review and discuss the implications and, potential, what's the way forward. So I'll go through the first part until the methods, and we'll spend most of our time talking about the findings from the review. So in 2019, the World Health Organization identified vaccine hesitancy as one of the 10 global threats to global health. And there are different definitions of vaccine hesitancy, and we'll be operationalizing that in due course. But basically, when you think about hesitancy, it's often in the context of reluctance or refusal to vaccinate, in spite of the fact that vaccines are available. And definitely this has a negative impact on stopping the escalation of vaccine-preventable diseases, such as measles, which, for example, has seen a 30% increase in cases globally. And we don't want to kind of simplify things. The issue is complex. It's not just about whether you're hesitant or not, but we'll get to that in a short time. So there is a WHO group of experts, the SAGE group of experts on vaccine hesitancy, who define vaccine hesitancy as delay in acceptance or refusal of vaccination despite availability of vaccination services. Obviously, like all definitions, it is not foolproof. It's been criticized for a few reasons, three of which we point out here. The first is that vaccine hesitancy is often discussed as a behavior, whereas hesitancy in and of itself is a psychological state. And then there's a tendency to use vaccine hesitancy as a term, which incorrectly includes people who have actively chosen not to vaccinate. They are not hesitant, they have chosen not to vaccinate. That's a different categorization, who do not fit under the vaccine hesitant group. And then vaccine hesitancy can also be wrongly used as to explain other things like under-immunization, whereas there are other issues in play. I was just recently working on a review, for example, on immunization among migrant populations. And there are reasons for under-immunization, several reasons, whether they are issues around their status and what access do they have, what rights are they perceived as citizens, and what does citizen we mean when you're a foreign national in a country because of you're in asylum for whatever reason. What does that mean? And then when you're talking about under-immunization among that category of people, then you need to think more deeply about the issue instead of just lumping it as vaccine hesitancy. Not to deny the fact that there could be vaccine hesitant people, and there are vaccine hesitant people in all populations, but just that we need to have a more nuanced understanding. So from a point of view of clarifying terminology, you can see that triangle, which is just essentially saying that this, you need to look at it in terms of a spectrum, a continuum. It's not either or, there are different people, and I mean different people are on different scales of, in vaccine hesitancy. If you look at it as a continuum, it'd be a more helpful way of looking at it so that you can incorporate the variety of the range of views that there are on vaccination, including just plain ambivalence, plain I don't care, it doesn't matter, and other context-specific issues. So we are moving away also from the idea of a very dichotomous view of, pro-vax, anti-vax. I mean, that, dichotomy is not very helpful. So we want to think about the broader range of issues. Just in terms of context, there are some things that distinguish, that are distinctive features within the Sub-Saharan African context that we need to bear in mind when we're talking about having these conversations about vaccine hesitancy. And we have, there's high disease burden, there are limited resources, there are leadership and government challenges. When we're thinking about high disease burden,
sorry, we are late.
Welcome. Yeah, a number of people have walked in, so we'll stop for a second and let them settle down. Yes. So we have some real people now, not just
when we fake people.
Sorry, we have an influx of people. So thank you for attending, and we'll just carry on with the conversation. So I was talking about the Sub-Saharan African context, and talking about high disease burden of both communicable and uncommunicable diseases. Child and maternal mortality is high. There's an increase of illnesses arising from climate change, environmental pollution, and then there are violence-related injuries, both at interpersonal level and in the when you think about fragile and conflict-affected states. And all of these contexts, we're talking about context because it has ramifications for vaccine hesitancy and how we should perceive it and how we need to look at it, or ways of looking at it that are context relevant. The Sub-Saharan African context, we also mark by limited resources. We have, under-resourced healthcare systems, whether it's healthcare workers, whether it's a physical infrastructure, financial resources, and even start. And there continue to be glaring disparities in access to healthcare. If we just think about rural and urban healthcare in Africa, that's enough to write a dissertation, a comprehensive dissertation on resource differences in such contexts. And then if you think about the spectrum of socioeconomic strata, which is particularly relevant in the South African context, if you look at the Gini coefficients, and there's such a gap, rich-poor gap, and that needs to also be factored in as we think about this. There are challenges related to leadership and governance, which are linked to our histories and political factors in post-independent countries as systems continue, governments continue to try and build health systems. There have been health reforms. We have, from the different countries represented even in this room, as I can see, but Zimbabwe, there's South Africa, there's Kenya. We all can talk about things like the IMF and the structural adjustment programs that were introduced by the World Bank, and what that did because of trying to grow, as we're trying to grow the health systems and then land into resource issues, financial issues, and get donor funded, and then all those things that come with it. And then in all of this, there has been the growth of public and private partnerships. And this is just the government's effort to kind of widen their nets and widen coverage of services, because the governments in and of themselves are not able to fully cover healthcare in low and middle income countries. And in our context, we're particularly speaking about Sub-Saharan African context. So some of the realities that we need to consider, if you look at the resources, if you compare, for example, North America and Sub-Saharan Africa. So North America represents 5% of the world's population, which is very small, 3% of the global burden of disease, and they have 25% of global healthcare resources and 30% of healthcare personnel available. As different from Sub-Saharan Africa, which has it represents 10% of the world's population, 25% of the global disease burden, 3% of global healthcare resources, and 1% of healthcare personnel. Those are kind of the disparities that we are talking about. And a recent study, it was a 2020 study on public health services in Sub-Saharan Africa, showed that 1 in 6 people live more than 2 hours away from their nearest public hospital. 1 in 8 people live 1 hour or more away from their closest health center. Those are the realities we live with. And very few countries in the continent, when we're looking at Sub-Saharan Africa, are actually living up to the Abuja Declaration, where the AU met and said, okay, we're going to devote 15% of government revenue for financing healthcare. If you scrutinize, and not even with too much of a microscope, very few countries in Sub-Saharan Africa actually devote that 15% of their resources to financing healthcare. COVID-19, of course, we need to just mention it. I'm not going to belabor the point, but it was like a huge magnifying glass in terms of showing the issues that exist already in the health systems. It was like somebody came and just showed us, look through, through the looking glass, magnified times, very high, 10 to the power 6 and whatever. And we saw the disruption of services, of non-COVID related health services, loss of livelihoods and economic recession, and people's trust, levels of trust. If you follow the media, people are like, why should we trust the government? We already don't trust them. So what is this vaccine? What is going on? There are very many issues that were there. And if you look at the disparities, and you're telling people to wash their hands and sanitize, And there are studies in Sub-Saharan African countries showing that only 33.5% of households had water and soap available. So it is really a moot point when you're trying to tell people to wash their hands and sanitize in such contexts. So our research question was what we sought to do in the scoping review. What we actually did was try to answer this question: how have researchers operationalized vaccine hesitancy and vaccine access as these variables relate to COVID-19 uptake in Sub-Saharan Africa? And our research objectives, we had a primary objective, which was evidence mapping of measurements of COVID-19 vaccine hesitancy, acceptance, refusal, access, and vaccine uptake. Well, a little ambitious, but well. The secondary objective was to identify gaps in literature as a preamble to inform development of contextually relevant measurement scale for future research on COVID-19 vaccine hesitancy, access, and uptake. So that's what we sought out to do. And we used a legit scoping review framework. I need not go into the details, but if you recognize, those are the scoping review frameworks that we use, Joanna Briggs and the Axie and O'Malley's scoping review methodological framework, and we used the Prisma tool in reporting. So that was our search strategy, and in the interest of time, I'll not go into the details, but you can see that we had, a particular, the general, we were mostly looking at general population and health workers. Then the concepts are there, as already mentioned. The context is Sub-Saharan Africa. Those are the databases we searched. Those are the search terms, and then we also did manual search of reference lists of full articles. So we did a lot of looking backward, forward citation kind of process. Inclusion criteria, we included primary empirical studies, qualitative, quantitative, and mixed methods, peer-reviewed articles, English. We were, had language bias here. We used English, even if Mike is completely bilingual and is French speaking as well. But I'm in the French department, je ne comprends pas, as much as I get. So we were working on this together, and we said, let's use a language you can work on and accomplish the task within the given period of time. And so the exclusion criteria were abstracts where we couldn't get the full text. Those that were non-peer reviewed. We excluded gray literature, which was limiting, but that's what we did. And then non-English articles, pre-COVID-19 publications, and duplicates, not Sub-Saharan African, and things that did not cover the scope of our content articles. So that's the flowchart of how we arrived at the 72 studies that we based this scoping review on. Mike will soon be reporting on what we found in terms of the findings. But that's just for, just to sort of legitimize our study and our process. It's been published, so it will be available, as Mike said. Those are the countries that were represented in our scoping review, the Sub-Saharan African countries represented. And in terms of sample populations, we had general adult populations and specific adult populations like universities, students, teachers. We had chronically ill persons, pregnant women, fully and partially vaccinated adults, mothers, adult caregivers, and informal traders, kind of this, the kind of specific populations. And then a number of healthcare workers and others where there was a combination of population segments. We couldn't, there was no logic model, but it could, whatever it was, but like we had to start with, school teachers and bank workers and healthcare and community workers, that sort of thing. So I'll stop there and let Mike carry on with telling us what we found.
Super. Thank you, Jennifer. And I think I'll just remind, it wasn't on the slides, but when we did the review and when we collected our literature, it was in, I think we collected March 2022. So between the time of the data collection for the scoping review exercise to the time it got published, there have obviously been more publications coming out on COVID-19 vaccination stuff. So in the 72 studies we looked at, there were 62 cross-sectional studies, 4 systematic reviews, 4 mixed method studies, only 3 qualitative studies, and then 1 which was a sentiment analysis of Twitter data, which is didn't just cover Sub-Saharan Africa, but it was a global study. So coming back to our overall research question of like, why did we do this scoping review? We essentially wanted to understand what were people measuring when it came to COVID-19 vaccine uptake, access, etc. And what we saw was that, well, there were quite a few different ways to do this. So some people were measuring willingness to vaccinate, that was 44%. Some were measuring intention to vaccinate. And again, thinking back to when these studies were done, what vaccines were available when, it's very difficult to capture all of that context when doing this type of work. 7 of the studies used multiple measurements. The 4 that looked specifically at uptake, we just used that as I mean, they said, were you vaccinated or not? I mean, that we didn't go specifically into seeing how they were measuring that. And then the qualitative approaches, which were different in the tools that they were using. So when it came to willingness to vaccinate, we have a few different samples of how that was done. Some of the questions were yes, no, or unsure type responses of would you be willing to accept a COVID vaccine when one becomes available? There were Likert scales. How willing are you to take a COVID-19 vaccine? So, you know, the responses can range from very willing to not at all willing. Some of them did add additional conditions to this in the questions and the tools that they were asking about willingness to vaccinate. So if it were available right now at no cost, so that was that extra condition that they added to the question about affordability. Would you agree to be vaccinated? Then again, the intention we saw, I'm not going to go into like all of the details of every single example, but this is just to show that we went from there's willingness to be vaccinated and then there's intention. Do you intend to do it? Again, we had similar types of responses, the yes, no Likert scale, and then the added condition of cost. And these are all coming from different studies as well. The ones that had multiple measurements, they didn't have one specific study outcome that they were looking at. They included several. Some of them, for example, asked healthcare workers about their own behaviors of will you get the vaccine? And then they asked also about their recommendations to their patients. So that they're measuring 2 related but different things. This other one was a systematic review, which gave an overview. And the way that he had done this in his study kind of used them all as a proxy for the same thing, which I think is kind of problematic. We're not exactly looking. Intention to accept is different than likelihood of vaccination, willingness, endorsement of the. So he measured up quite a few things, but I think that systematic review just also shows how complex these types of measurements are and how maybe we aren't being as systematic as would be ideal in this context. And then this other one looked at respondents' willingness to participate in a vaccination trial and their willingness to get the vaccine, which again are very different questions. The qualitative approaches, some of them used focus group discussions and looked specifically at conspiracy theories and misinformation. These others did qualitative interviews with healthcare providers. They used the WHO definition of vaccine hesitancy. And then this other group came back to a vaccine anxieties framework that they had used in 2015, 2016 before the COVID pandemic. And they were trying to look at this framework in the context of the COVID-19 vaccine rollout. So that was kind of the first chunk of our study. We were interested in what are researchers measuring when it comes to vaccine uptake, vaccine hesitancy, vaccine acceptance. Another key part of the picture in vaccine decision-making literature, vaccine uptake literature, is the issues that Jennifer was talking about in the context on this is what are people's access to these services like? And what we found that all 72, they wanted to study issues of hesitancy or acceptance and uptake, but only 16 included explicit measures of access, which I think in the Sub-Saharan Africa context is kind of problematic. And I think we can do better than this in this type of research. But the ways that we saw that people were actually measuring issues of access, they were looking at cost and affordability, and that was 13 studies. Measurements around convenience. Some studies did look at distance or time to travel or time waiting for a vaccine. One included a measurement of comfort, and then one qualitative study looked at access issues, and I'll talk about that. So 8 of the studies included what we've already seen in some of the other measures, which is this condition of at no cost. So that was kind of how they had, for us and how we categorized it, this is how they had covered that access related issue of looking at cost and affordability. Others looked at specific things like if there's a vaccine right now available, I think it should be free. Others asked people how much they would be willing to pay for a vaccine. And I think this was at a stage when it was also looking at intentions for the future of deciding what would be an acceptable amount to ask people to pay. Others looked at issues of convenience. And so one of the studies asked very simply, like, do you find vaccination sites hard to access? So that's a really nice way to find out, are people able to access these services? Others asked about the online registration platform, and others asked about preference for where they would like vaccinations to be administered. Others, and these ones are quite simple, but distance or time to travel, or time waiting for a vaccine, just asking, how long will it take you to get to the vaccination center? Are you willing to travel more than 1 hour to get a COVID-19 vaccine? Which I think these are quite nice indicators to see, this part of the puzzle. And then one specifically asked about level of comfort when you go to a vaccination clinic. They said visiting the clinic makes me feel uncomfortable, and people had to say how much they agreed with this statement. And this will keep me from getting vaccinated against COVID-19. This is more, I won't go into this super detailed, but this is going back to the vaccine anxieties framework, and this is how it was looked at in terms of access with the qualitative research. I'll leave that here for you, but you can look into that if you're more interested. So as part of the scoping review exercise, we wanted to really understand what are people measuring and what aren't they measuring, or what aren't we measuring enough of. So we saw that, and like I said, a small proportion of studies are explicitly investigating issues of access as a determinant of uptake. There was a lack of standardized homogeneous approaches to measuring COVID-19 vaccine hesitancy, acceptance, refusal, and access. We saw it as very diverse and very many different things that people are looking at. And we did see that there's a lack of countrywide representative studies. And I think that's a lot of realities of doing research during the COVID pandemic has been quite challenging, and getting representative studies is generally a challenge anyways. So what does this all actually mean, and why is this important? So we saw that there's a diverse way of studying this, particularly in terms of study sample populations, study settings, study designs, and measurement tools. And like I said, there's been a lot of focus attributed to COVID-19 hesitancy, acceptance, refusal, whereas few have included explicit measures of access. And this is, I think, what this is kind of, we're trying to understand why is it the way this is. And what we saw was actually that few of the studies actually, that they meaningfully engaged with this literature that predated the COVID pandemic. A lot of researchers, I think, and this is the impression I got reading these studies, they just kind of wanted to understand what was going on as quickly as possible, but they didn't read a lot of the stuff that existed before and saw what the tools that they could be using. So some of those did look at literature predating the pandemic of this 3C model.
The same is that auntie that was in Brutus Kitties, there is auntie. She paused on, and she's out of her misery. Yeah.
People in the audience, can you make sure you're on mute, please? So some people use the 3C model, some people use the 5C model, which has been an updated version of that, and then others are engaging with the
We lost the sound there.
Sorry about that. I hope you can hear me now.
Yes, we can. Thank you.
Okay, super. So with this scoping review exercise, we identified an empirical blind spot regarding measurements of access to vaccination for the rollout of COVID-19 vaccine. Future researchers and practitioners will need a more solid understanding of and a better evidence base around this to get insight into concrete, pragmatic, and actionable changes that can make it easier for people to get COVID vaccines. And then for this to be possible, we need standardized measurement tools, and cross-country collaboration will be key for this. So I thank you for listening, and happy that we have people in the crowd that aren't just our DSBS groupies. And we would be happy to hear from you from questions, and then also looking forward to the future. So if you have any questions or comments. Yes, I'm gonna stop sharing and then jump on over here. Wow, we've got quite the crowd over there. Okay. Any questions or comments out there from people in the virtual group? Question here in the crowd.
What's the difference between willingness and intention to vaccinate?
So the willingness, looking at intention is there are very much questions of like, do you intend to do it in the future? And I think a lot of these studies were done at a time when vaccines weren't yet available. Like, do you plan on getting one if it's available? Willingness is how willing are you to get the vaccine, like right now? So there was kind of a difference in the temporality of it.
In terms of outcome, what's the difference? But what they should to tell us about, like,
I think the intention is, it was a very hypothetical kind of, they weren't available yet, but it's kind of getting the data ready to be like, how much will people be getting vaccinated in the future?
So now the vaccine is here. So what is the most appropriate question? Willingness or intention?
I mean,
No.
we didn't determine that from our scoping review exercise. We're not kind of rating the quality of their measurement tools. We just collected what are people measuring.
Nita from MRC.
Did they raise their hand?
Yeah.
Hi.
Is it, yes.
Hi, thanks very much for the presentation. It's Nita from the SMRC. So the reason I put my hand on it because you've partially answered the question. I mean, originally you started off with saying context was important, but I think you just explained that you didn't measure the quality, because as you defined willingness and intention, my question was, did you look at the type of questions that was asked to generate responses? But I think the issue is that the quality wasn't explored. So you've answered me. Thank you.
Yes. So, and that's kind of to be clear about the purpose of a scoping review exercise doesn't look at, we're not kind of assessing the quality or evaluating the quality of the studies done. And we also didn't summarize the findings presented in the studies. We wanted to specifically look at what are people measuring and how are they doing it. Any other comments, questions? Yes?
Thanks. Sorry, it's a little bit off topic, but I
Sure.
recall, well, it's related, but MRC ran that massive vaccine trial, and just to bring your attention to the fact they also did a vaccine hesitancy survey. It was a very interesting audience because all of the employees had, ready access to vaccines. And so trying to answer that question as to how does hesitancy deflect from government's responsibility, there's this kind of captive study where there's no excuse around access. They have perfect access, and so you can get a kind of pure measure of hesitance. it's a biased sample because it's all people working for a medical research council, so very, very low. But interesting to find there was vaccine hesitancy there as well. Just out of interest. I don't think it's been written up yet. I expect it will appear at some point, but it does speak directly to that issue.
Yeah, I would be really curious to see the study results for that. And I mean, on a similar, it's not from our scoping review, but some of the work that I've done here was interviewing government officials and authorities about the planning of the COVID-19 vaccine rollout in the Western Cape. And what I was surprised by, so this specific group of people I did qualitative interviews with, was how nobody expected people to be hesitant. Like, it was a surprise to the people rolling out the vaccine that people wouldn't want the vaccine, which I just find really fascinating. I've been in this space for a long time, and then I was expecting a lot of people to be hesitant. Yeah. So to hear from the people in charge of the program that wasn't an expectation, I was quite surprised by. Yeah.
Hi, everyone. My name is Camila. I'm from Brazil. I've just arrived here. I'm here as an international PhD student. Professor Charles is my supervisor. And when you were talking about the added conditions, you mostly talked about cost, right? Did you find any other added conditions besides cost?
I would have to think about it back to when we looked at it, but I think that was the main one that we had seen in a few of the studies of, like, if it's available at no cost. So it was just the same basic questions others were asking, but then they added that kind of caveat to the question.
And could you please, I'm not from South Africa and the continent at all, but could you please explain me a little bit about this cost thing here, like here in these countries, Sub-Saharan countries? Is it common, like paying for vaccines, or mostly they are for free? How does it work?
So the COVID-19 vaccine rollout has been at no charge to the service users in South Africa, and I think most Sub-Saharan African countries just provided the vaccine, the COVID-19 vaccine, at no cost. And I think that was part of CoronaVax. That was a big international project organized between UNICEF and the UN to make sure that vaccines could be affordable for people at no cost.
Like, there's a comment in the chat.
Yes.
Maria, and then someone else is typing.
Check it to the chat. I don't know how to use Teams.
I can read it to you.
Okay.
It says, in 2021, COVID-19 vaccine uptake was higher among staff of Provincial Department of Education, 80% plus, than Department of Health, 60% plus. So I think that's kind of interesting in reflecting on Richard's comments about the MRC. So it would be interesting to see what the MRC results look like. Yeah, so that was just a comment. Peter Deml has his hand up.
Okay. Yes, Peter.
Hi, Michael. Thanks for the presentation. I was just wondering, as you know, we did the COVID-19 vaccine hesitancy survey, or study rather, among healthcare workers, qualitative. We also found that the issue of access was problematic at the onset mostly. So I'm not sure, I don't want to put anyone on the spot, but I know that some people from the government online, I would like to hear their comments on the relative importance of access as a variable in the whole uptake discourse. Thanks.
Cool. So you're putting that onto some other people in the crowd. We'll see if we get any people to respond.
Well, I know that Virginia and Gavin are online, so maybe I don't know if they care to reply to give a little bit of insight into how the access issue has been tackled at the province level.
And then, Peter, just maybe to clarify with your question, were you were thinking about the healthcare workers, and they mentioned access as an issue at the beginning, and that's their involvement through the Sisonke trial as well, of like how they were getting the vaccine?
Yeah, definitely. Well, it was at the onset, it was just a matter of structuring and logistics and getting the thing organized, but then it became a more a smooth process. So then those things were ironed out. So I'm just trying to put the access issue in a bigger picture to see, well, to what extent it indeed plays a role in the whole vaccine hesitancy narrative, if you want, because this is the topic of your review, but just to give it some, well, to put it in the right place or give it the right weights, if you want. That's what I'm trying to figure out.
I don't know if we're going to get any responses.
Doesn't look like it. No.
So I think we'll leave that as some food for thought and hear if there are any other questions from or comments from the here in the room, or I don't know how to find the people online.
Oh, there's a hand. Oh, Gavin's got his hand up.
Okay.
Yes, hi. Thanks for the chat on the hesitancy. I'm not sure what you mean, Peter, by access. I mean, there was excellent access to all health department staff. So of course, health department staff had first access to the vaccine, and there was a process. I mean, there was a logistics of organizing it. Was that it did it section by section within the health department, and if your section had already been covered, but you didn't want to take it up then, I mean, in a sense, you had an opportunity to think through your hesitancy if you first want to see what happened in terms of side effects, etc., with your colleagues beforehand. So over a series of months, you could have taken up the vaccine. Having looked at the experience of what's already happened, and you know, the vaccine was delivered during work hours, so and at facilities with organized transport and so on to get to specific facilities where it was done with appointment times and so on for groups of people. So access was pretty good for the health department staff to begin with. And then after that, of course, they could have accessed it at any vaccine facility. And again, lots of encouragement. And so there was no barrier to access for health department staff. So the hesitancy with regard to the vaccine would not have related to access. Thanks.
Thank you. And I don't know if Peter wanted to respond or not.
There's a hand from Charles.
I don't know where to find it.
There's a hand from Charles.
Okay.
Yeah,
Charles.
Yeah. Hi, Mike and Jennifer. Thank you for the excellent webinar. I just wanted to make a general comment, and it's related to, you know, the criticisms that Jennifer talked about that were levied against the previous definition of vaccine hesitancy, and also the best tool that you also indicated there. So because of that criticism, that WHO definition, it does seem that they have now endorsed a different one, which is different from that first one, which people still use, where there have been a working group that has worked through with within the context of WHO to come up with 4 domains of behavioral and social drivers of vaccination more broadly, and not just hesitancy. And where these domains include things like thinking and feeling, which includes the cognitive and emotional responses of people to vaccine-preventable diseases and vaccines, social processes, which includes things like social norms about vaccination and receiving recommendations to be vaccinated. Then there is the third domain is motivation, which includes intention and willingness to be vaccinated, like you've indicated, and then practical issues, which includes the experiences that people have when trying to get vaccinated, including barriers. And within this 4-domain framework now, vaccine hesitancy is part of the motivation domain. And now the definition that this group has come up with WHO and SPH have endorsed, is that vaccine hesitancy is now regarded as a motivational state of being conflicted about or opposed to getting vaccinated. And I think this came up a bit quite clearly when Jennifer talked about because the former definition regarded vaccine hesitancy as a behavior, but when we know that it's more of a psychological state, or in this case, a motivational state of being conflicted about or opposed to getting vaccinated. So that's why just general comments. Over to you.
Super. Thank you so much for that, Charles. It's very good to see that there's movement about that and that the definition is being updated with the WHO. Sorry?
So, as a conclusion, do you think, like in South Africa or in countries, it's like as a result from the scoping of the work we are doing now, to use like the phase 2 behavior, which is like a very comprehensive tool, or to come up with our own tool, like use the existing tools like 75, adapt them, or it's better to come up with our own tool, which is hard maybe.
Yeah.
So what do you think?
Yeah, so the question, I don't know if everybody heard online, is what do we think about creating a new tool and in order to measure some of these things specifically for this context, or is it better to use pre-existing tools and kind of just being able to, and I would agree that I think it's important to use pre-existing tools or adapt ones that already exist, so then you can have something to compare it to that it's a bit systematic in a sense, but it's also important to be able to measure things that make sense for the specific context here.
Can we still ask questions and remove questions from those tools, like this is methodology?
Yeah, that's a methodological question and a decision to make, but I think it's completely fine. It depends on what your study goals and your what exactly it is that you want to do. But I think the tools are there to be used and then adapt them if you want.
Thank you.
But make sure you document that.
Of course, yeah.
Great. Okay. Unless there's anyone else who has any more comments or questions in the chat online. No. I think that we can close. Thank you very much,
Right.
Mike and Jennifer. Safe travels, Mike. Come back and present more interesting results to us at another new meeting in the future. And thank you both very much. Lovely to see everyone online. Next time, let's try and do this in person. Come and visit us. Nice to see the people that are in the room. Thank you very much for coming. Sorry about the different space. But yeah, thanks very much. Have a lovely Thursday afternoon.
Thank you, everybody.
Thank you all. Bye.